Very much. We're going to go a little out of the original order to accommodate a travel need. Professor Erika von Mutius from the University of Munich in Germany is here. She's a investigator, a journal editor, and we're going to take her out of the slot we originally had slotted her on to allow her to allow us to learn from her and also to give us a chance to ask her some questions. So thank you very much for coming. Look forward to your talk.
Well, for allowing me to present here. I'm out of the European jungle. I think this is going to show you or share with you some of my experiences in Europe, basically. So I'm a pediatrician and an epidemiologist. So most of my experience is not with clinical trials, but it's with observational population-based studies, and I have had research grants from many sources, the European Research Council or Commission, German research, also some stuff from a Friesland Campina. This is a dairy industry in the Netherlands, but this is mainly to do observational research. I have been consultant to some of these companies here. It's just to mention, it's not that I have done any clinical trials with them. But, you know, we've heard so impressively from Mark, and I couldn't agree more. It's a jungle that you enter if you do these sort of things. And just to share with you what we've been doing, we did a Gabriel GWAS studies. This is about 5 or 6 years ago. And we had, all of these were population-based studies, mostly in children. That adds to the complexity. Nobody has today even stated that, you know, if you talk about consent forms for children, you even have a little bit more of an issue. You have in different IRBs who have different ideas of whether you should consent the child and what type of consent you should get from the child and what are the age ranges in which the child should be asked instead of the parents, and if you need agreement from both of the parents or just one parent, and so on and so forth. So there are a number of issues that if you go into children's studies that are even more complex. So anyway, this GWAS study had 22 studies, already performed population-based studies in a number of the countries that, European countries that you have listed here, also some in Canada and Australia. And the, some of these were multi-center studies. So, for example, the European Respiratory Health Survey is a service about, I think it's about 15 or 16 European countries, which is one big European survey. So the aim was to get the DNA from people with asthma and without asthma to do a genome-wide analysis. That was not an easy task. We finally, and this is, you know, to uplift you, it's possible. It took 2 years, a person to trying to bring all this information together. We had to ask about ethical permission, of course, informed consent. We had first of all, to standardize things. All of these studies have used different outcomes for asthma. Some people call it wheezy bronchitis, some people ask it's lifetime prevalence, some people ask it's symptoms in the last 12 months. So the first endeavor was really to standardize that everybody would give at least the most comparable outcome that we needed. We had to go through these ethical approvals in most of the countries. And in these large multi-center studies, it was not sufficient to talk to one person. They had to convene and to talk to all of their PIs because they were in all the different countries. As I said, the ECRHS was in 15 or 16 countries, so you had to wait for the annual meeting to discuss this with them. The other thing was that setting up a common database is not trivial because you get all these little pieces of information. We got the DNA, but we also got a very limited data set, anonymized data set in this case, but you have to set that up. Then eventually we did the central analysis and the publication, and now because at the end there was also some money involved from Wellcome Trust, there's an open access of anonymized data. The European Commission does not have this. I think we heard it really elegantly from Mark, all these different approaches in Europe. So this is one experience. Just saying it's complex, it's tedious, it's time-consuming. But if you have a high goal, like you want to be one of the first GWAS studies for asthma in children, then that works. The other, just about the implementation, the other experience I have is I'm a coordinator of a number of these multi-center interdisciplinary studies. So all of this is in children. Large numbers of people involved, be it environmental samples, blood samples, genetics, microbiome, et cetera, et cetera. And we have defined outside of this consortium what is an associated study. And so we have made our own rules and say outside associated studies are researchers outside of the consortia listed, and they are generating and analyzing data. And so we have made up our own rules. And this is just to share how maybe that is important. We felt it is important that people have to formulate their aims and hypotheses. Basically, what we expect from people who approach us is that they give us a one-page summary of what they want to do, and this is what we ask them to give us. We want to see the aims and hypotheses, and I think importantly, we want to they need to show that the available data that we have are adequate to answer the aims and hypotheses, and we want to precisely define which is the outcome they really, the variable in the data set they really want. We want to have a detailed statistical analysis plan. And then, of course, the collaboration with the consortia members of those already existing in a consortium needs to be defined. And we have already a very detailed publication guidelines that says how publications in such a case of an associated study could fly. So I think this is mostly what I wanted to share with you. If you implement these studies, I think there are incentives, at least from a European perspective. Of course, the Gabriel study did fly because we thought we were the first to do this. It was published in the New England Journal. That was the goal, and we luckily succeeded. But this is why everybody at the end came on board. Of course, we have, in this case, we had a shared research interest, and in this case also, the GWAS was only possible if everybody contributed. Nobody could do it by him or herself alone, so I think that was a strong incentive. And maybe in Europe, because of these European funding schemes, there's a certain culture of collaboration. But the biggest obstacle, I think, is mistrust. Trust in these consortia and outside the consortia is important. Trust and transparency, I think they go hand in hand. Of course, obstacles are competing researchers, competing institutions. And then, as I said, it took us 2 years for one person to assemble all of this, and I think we have heard this yesterday. It's a huge amount of time, time to do this, and also expertise. You have to have an infrastructure where you can do these databases, somebody who knows how to do these things. And I think this is mostly what I wanted to share with you. Thank you.